So this is some of the same theme, but there are some different principles when you're managing an athlete. And what I thought I would do is just highlight some of the thinking of when it comes to managing these individuals, because it is a bit different compared to individuals who have difficulty with activities of daily living or even lower level sports. One of the first interesting issues is why some of these patients hurt. You saw a number of defects today in surgery, and the interesting aspect is these are extraordinarily common. Probably 25% of the population below the age of 40 walks around with these, but yet many of these don't have any symptoms. And one of the ways to think about it in terms of what may or may not cause symptoms, if you look at this D1 female soccer player, she has a defect there that's filled in fibrocartilage after marrow stimulation, but the surrounding area is relatively healthy. But the size of that defect relative to the width of the femoral condyle may be very relevant. In other words, she has a relatively small condyle, but a large area that's affected, and she may have lower tolerance to this defect. Place the same defect in a male where the condyle is much bigger, he may actually not even acknowledge it. So some people coexist and are copers, and others just can't tolerate it and have significant pain and dysfunction. What we often get asked by our athletes is, now that I know that I have this problem, what if I continue to participate in sports? Am I going to make my problem worse? And this is a little research project we did looking at the literature, and the take-home was that there is insufficient evidence in the literature, other than obesity and a history of previous surgery, that participation in high-level sports will cause these defects to progress. So who gets what in the athletic population? Non-operative treatment is still the mainstay. If they have an acute onset of symptoms where they have good performance or in their last contract and academic year, these are people who want to play. So we'll maximize non-surgical treatment. But if they're playing and their performance is impaired, they have the time to get better, they've failed non-surgical treatment, maybe they're early in a long money contract or in a scholarship situation where they can actually redshirt, these are individuals who may be operated on. I sort of call it the day of reckoning. When you make a decision to operate on an athlete, they really have to have failed non-surgical treatment. They have to have unacceptable pain and dysfunction. If they can accept it, we're going to ignore it and treat it with benign neglect. I always ask them, what would you like to see improve? You saw that in the history videos from the surgeries today, because if their only answer is, well, look, I just don't want a knee replacement when I'm 50, but they're tolerating it fine now, that's not a patient we wish to operate on. In addition, if they have anterior knee pain but a medial femoral condyle defect, for example, those symptoms may not be synchronous. So you have to know what you're treating, and if you're actually going to deliver to them something that's going to address and be synchronous with their problem. So is it going to predictably deliver what they're looking for with minimal risk and meaningful upside? And then finally, whenever possible, osteotomy is an option. That's something that can endure high-impact sports, and we try to do this. It's very important to manage their expectations. These solutions are not often off switches, in other words, turning the symptoms completely off and normalizing their activities, but they actually are almost like a light rheostat. They sort of down-regulate the way they feel, but they're not perfect. These are some other things to consider. What is the least amount that one can do to make them feel better? What will endure his or her habitus, the sport they participate in, and the loads imposed? What will provide the fastest recovery? What will keep them out of the operating room again and not burn any bridges or compromise the asset value of that athlete? And what will most likely get them another contract? So there's this whole spectrum of things that we offer. You've seen virtually every one of these today. And the reality is that when it comes to these athletes, most of them get what you saw in that last arthroscopic case today, debridement. And then they often get another debridement, and then they get another debridement, and then they have time to actually get better with something that may give them more longevity, but they can step outside of their athletic endeavors. So marrow stimulation is still performed to the tune of about 130 to 150,000 times a year. So it still is a dominant treatment strategy, right or wrong. Osteochondral allografts are becoming more prominent and prevalent in highly active individuals. So we're stepping over some boundaries over the last couple of years where we're deploying this earlier rather than later. And then finally, osteotomy. Whenever possible, we try to realign them, maybe stay away from something that could be vulnerable when they return to sport. This is a study where we looked at patients who underwent biopsy for ACI, now MACI. And what was interesting is that 44% of them were never implanted because 60% of them after their debridement felt better. So that girl you saw today that we debrided her patella, if she feels well, I really couldn't care less what her MRI shows, what her defect showed today. We will leave her alone and allow her to participate in sports. So the point is that many of these patients will get better with just simple debridement. This is another series of patients from Jimmy Andrews' population, where 52 high-level athletes in the NFL, 67% of them return to play after debridement. So the point is, it is a viable option for the high-level athlete. This is an NBA player. You can see the MRI on the bottom right doesn't look so good. At arthroscopy, there's a localized defect that you see here. Patient had pain and swelling and was in his last contract year. And within 3 weeks after that simple debridement, he was back at full go. He's now 3 years out with a veteran contract and has not had a recurrence of symptoms after a simple debridement. So despite how bad that MRI looked and even the x-ray looked, we're able to get him better and continue to play with minimal effort. Marrow stimulation does have precedence in athletes, and there are a couple of reasonably good series that show that up to 80+% of them can return to sport. If they really need the results of that marrow stimulation, it's going to take 8 to 9 months sometimes. This is a D1 senior who was at DePaul, was going out into the WNBA, and she had failed 4 weeks of rest, an intra-articular injection, had a little cartilage defect, small meniscal tear. She came to surgery, had this little meniscectomy, which I think wasn't contributing to her symptoms, had debridement of this defect that you see here and loose body removal. So then we're in a situation to say, look, is this going to be enough? And that's where you really have to focus on the patient's symptoms and say, can I stop here, do the least amount necessary? But she was coming out to the WNBA. She hopefully has a long career ahead of her. She had weight-bearing pain that I didn't think the debridement was going to do enough to get her well, and it's a small defect. So we continued on that same operation and did marrow stimulation. And in fact, it took her 8 months before she actually felt well enough to play, and she's been out for 3 years now in the WNBA. But I believe she really needed that marrow stimulation. We sort of guessed right to get her well. Osteochondral autograft transplants, you saw one of those today. I'll tell you that that's the first one I've done in over a year, okay? So it's very rare that that procedure is needed, but the literature is actually very supportive that compared to marrow stimulation, all else being equal, patients with an osteochondral autograft, where we take a plug of bone from one part to another, can do extremely well in high-level sports. Similarly, ACI has been looked at in elite-level soccer players through various reviews, just carving out the athletic population. Return to play following ACI and MACI can exceed 75%. So the right patient matching to the procedure, many of these operations can get a patient back to high-level sports. Osteochondral allograft has pretty much become the go-to for me for the knee and the shoulder, and now sometimes the elbow for radiocapitellar problems, and especially in gymnasts. It's very versatile. You've seen how easy the operation can be, especially with patients who have failed previous cartilage repair procedures. This is an NBA player. You can see on the left, has had a number of previous procedures that continue to have pain. Had 2 defects, a trochlear defect and a femoral condyle defect. And after failing initial treatment, undergoing allograft treatment, we were able to get him back to play. Now, it's interesting, there are 2 bodies of literature that have looked at active patients in the allograft population. One is the military, and the other is sort of everybody else. And what's fascinating is the military probably has the largest challenge in getting these guys back to activity. So they're sort of like the work comp patient on steroids. Very difficult to get someone in the service back to full activity after virtually anything. And we've seen that in this with superior labral tears, we've seen that with instability, and the same thing is true for cartilage. Now, we've had an emergence of a number of allografts. You heard Christian's talk on biologics, and the main reason that we see all these allografts now is that the regulatory hurdle is very low. These products are minimally manipulated tissue, so it paves the way for a number of these different opportunities, most of which are sponsors for this course, and you should have a look at these. So where do we use these? Well, this is an example. This is an Olympic-level wrestler who had a defect of the femoral condyle, also had this tibial lesion. His alignment was normal. Was just not interested in osteochondral allograft. We did a de novo procedure, which is minced juvenile cartilage that you've seen. I think Jazz did that lecture. And then we performed marrow stimulation of his tibia. And in fact, he was actually able to get back and participated in the 2012 Olympics. So again, a lot of ways to solve these problems. This is another 24-year-old lineman who had intersighted knee pain, a pretty aggressive lesion there. Absolutely did not want an allograft. This is the defect at arthroscopy. It's interesting that, as I commented before, many times the intra-articular representation of what goes on the MRI is very different. MRI looks a lot worse than what you see arthroscopically, but that being said, this is pretty bad at the time of arthroscopy. So we treated the lesion, and we treated what we thought was going on in the subchondral bone. So we drilled the lesion. We used dehydrated collagen or biocartilage and bone marrow aspirate, combined it with fibrin glue. And this is him. And it's interesting, if you look at his MRI, it's been completely reconstituted. So again, a lot of ways to get it right. You could do a sandwich technique. We could do osteochondral allograft. It's very difficult to say this is the one single solution for these patients, as many of them may work as long as you treat all the comorbidities. So that's a good segue just to finish up. The main comorbidity that we deal with is meniscal status. This is a woman who basically played high-level tennis, was also a runner, had a meniscectomy, as you see on the top images. Within 6 months, this is what happened to her. Her joint just deteriorated. So you can see the tibia's gone bad, the femur's gone bad, and she has no meniscus. So what was done was an osteochondral allograft and a meniscal allograft. And she did extremely well, but she still has problems with abrupt stopping and pivoting. She's able to run. She can't play tennis because it still bothers her, and she'll say she feels achy on occasion. Following meniscal allografts, as Alan talked about, they too can go back to sport, but this is one that I like to leave out in the population whenever possible, just because of cutting and pivoting and the risk of tearing their meniscal allograft, just like they tore their own tissue. But sometimes it's needed to actually get the pain relief they require. And the final comorbidity is osteotomy or malalignment. What we've shown is that just a little bit of correction to about 3 degrees of valgus is enough to unload the medial compartment by about 70%. So these young patients really don't need to have very large corrections. So this is just one example. This is an soccer forward who had a valgus alignment, had a focal cartilage defect of the femur, was realigned, and at the same time an allograft was placed. So anytime we could do an extra-articular procedure to realign them, that's the lowest hanging fruit that we have. And there's pretty decent data that shows that we can get these individuals back to sport. Again, the military is that other population which is probably the most challenging, but we can even get the high-level recreational or elite-level athlete back. So in summary, cartilage problems are often incidental, and generally speaking, most of us will ignore asymptomatic defects. So non-operative treatment is really what's desired for the performing athlete. Short-term solutions such as debridement can be performed for the competitive athlete, and they can be performed again and again if need be. Longer-term solutions such as allografts, ACI, osteochondral autografts, and so forth are very good when the short-term solutions fail. And the younger patients, smaller defects, shorter duration of symptoms are the ones that really do the best in virtually any literature that we have to review. I think that we have to be a little bit cautious when we start citing our return to play data, mainly because return to play is multifactorial. There are several issues. There can be roster changes. It depends on what year of the contract. It could be the number of individuals that are playing around that. It could be agent-driven, could be coach-driven. So when we cite that it takes 8 months to get back to play, there are lots and lots of other factors that are outside of the defect or the problem that we're being treated. And that holds true for anything from shoulder instability, labral repair, ACL reconstruction. These return to play numbers have to be looked at very carefully because it may have nothing to do with the problem that we're even treating. So just in conclusion, I just want to bring your attention to one other course that you might find interesting. This is the first annual, 19th year we've had it, but the first time we've combined 3 subspecialty societies for a ski course that will be in Park City, Utah, that will be almost exclusively be case-based. And there's a physician extender track and a physical therapy track, and we'll have Kevin Wilk there running the physical therapy side. And this will go from January 31st to February 3rd in Park City, Utah. So we'd love to see some of you there. Thank you very much.